Hi, I'm here today to talk to you about low back pain and pelvic floor disorders. I would like to begin this presentation by giving you some background information. First off, greater than 85% of patients seeking primary care have nonspecific low back pain. Individuals with low back pain have a significantly lower pelvic floor muscle function compared to those without low back pain. In addition, urinary incontinence, respiratory problems, and GI symptoms are associated with the development of low back pain. Interestingly enough, urinary incontinence is greatly increased in women with low back pain, with stress urinary incontinence being the most common. This is where involuntary leakage occurs through activities that increase intra-abdominal pressure, such as sneezing and coughing. Now, as you can imagine, this can be a barrier to regular physical activity and decrease one's quality of life. According to Nygaard and colleagues, quote, over 25% of all women and more than a third of women aged over 65 years will suffer one or more pelvic floor related symptoms during their lifetime, with symptoms ranging from bothersome to debilitating, end quote. A lack of pelvic floor muscle function can be related to a loss of motor control characteristics as well as trunk instability. Some key risk factors include pregnancy, childbirth, increasing age, hormonal changes, and lifestyle issues such as obesity. Now let's review some of the anatomy of the muscles that we will be targeting, which include the four walls of the core composed of the abdominals, the paraspinals, the respiratory diaphragm, and the pelvic floor, which is composed of the levator ani and the coccygeus. There are actually three structural systems which comprise the anatomy of the urinary continence system, including the intrinsic urethral closure system, the urethral support system, and the lumbopelvic stability system. Here's a picture of the pelvic floor musculature in its entirety, as well as the levator ani in the female, the levator ani in the male. Here's an inferior view. Here's some pictures of the coccygeus, as well as the iliococcygeus. You might be asking yourself, how are these patients going to present when they enter your clinic? Well, many women with pelvic floor musculature dysfunction present with a posterior pelvic tilt, decreased lumbar lordosis. 78% of women seeking physical therapy treatment for low back pain reported urinary incontinence. This is primarily due to insufficient activation of the postural musculature that was mentioned in a previous slide. Now, important red flags to screen for include cancer, infections such as urinary tract infection, and Cauda-Equina syndrome. A useful self-report tool is the Incontinence Severity Index, which has been validated in several studies. Now, during the examination, there is a variety of ways to evaluate the pelvic floor musculature function. When evaluating the ability of the pelvic floor musculature to contract, methods of measurement include digital palpation, ultrasound, MRI, and EMG. When measuring pelvic floor musculature strength, clinicians can use manual muscle testing, manometry, dynamometry, and vaginal cones, which we will speak to in a later slide. Now, at this point in your evaluation, you should have an idea of the patient's efforts towards conservative interventions such as physical therapy and whether or not it was successful. You should also take into consideration the severity of the incontinence and its impact on the patient's life. If the patient was unsuccessful with prior physical therapy or has frequent accidents, you might want to familiarize yourself with some of the common procedures used to correct their particular pelvic floor dysfunction and the associated risks. These procedures include surgical slings, intravaginal injections, and/or functional electrical neurostimulation. The two biggest risk factors are undercorrection, which commonly results in persistence of pelvic floor dysfunction, or overcorrection, which commonly results in overactive bladder. Now, it is important to keep in mind when managing patients with pelvic floor musculature dysfunction that 50% of women delay seeking treatment due to reduced health expectations, perceived inevitability of symptoms, social stigmas and embarrassment, and just overall low expectations of perceived efficacy. Additionally, 30% of women do not contract their pelvic floor musculature correctly at their first consultation, even after thorough individual instruction. Common substitutions to monitor include activating the abdominals, the gluteals, and the hip adductors. The three modifiable factors that we can work on as physical therapists are: first, the motor control factors, such as neuromuscular reeducation of the pelvic floor musculature, postural and movement dysfunctions, low back pain and pelvic pain, and breathing disorders. Secondly, musculoskeletal factors such as decreased range of motion, strength, and endurance. And thirdly, behavioral factors, which we address in many aspects of physical therapy care. These include physical inactivity, abnormal fluid intake, voiding patterns, poor psychosocial health, so on and so forth. Now, according to Sapsford, stages of pelvic floor musculature rehabilitation should include: first, diaphragmatic breathing; secondly, tonic activation such as conscious activation of the pelvic floor musculature such as Kegel exercises; thirdly, muscle strengthening, activation of the pelvic floor, walking short distances; fourth, functional expiratory patterns, so contracting the pelvic floor musculature and increasing intra-abdominal pressure by coughing, laughing, holding your breath, or bearing down; fifth, impact activities, which at this phase we want the pelvic floor musculature activation to be more of an unconscious activation to promote increased functional activities. Now, all of these exercises will progress from supine to sitting to standing. Here's a picture of an exercise that includes bridging with abdominal bracing. Now, this exercise activates the pelvic floor, and we would want the patient to perform 5 reps of 10-second holds 5 times daily, twice weekly. In the following exercise, the patient would activate the pelvic floor, then increase intra-abdominal pressure by taking a deep breath in and holding it for approximately 10 seconds. Now, we'd want the patient to perform this multiple times throughout the day, so throughout their activities of daily living. Patients would also benefit from stabilization exercises, so we would want to target primary stabilization muscles of the spine, and we can also provide the patient with biofeedback using ultrasound during neuromuscular reeducation, and vaginal cones, and they can be used for strength as well as endurance. A set usually consists of a series of weighted cones. The patient will progress to a heavier weight after a weight can be held in place for at least 3 minutes with functional activities. Now, this will help promote an unconscious contraction of the pelvic floor musculature. This is a chart from a study by Guru et al. It provides specific interventions based on certain subjective and objective findings a patient may present with. Now, generally, patients have a good prognosis on the contingency that they not only comply with their home exercise program throughout treatment, but after treatment has ceased as well. Castro et al. Determined in a single-blinded randomized clinical trial that those with stress urinary incontinence in particular do significantly better with pelvic floor-oriented treatment than with no active treatment at all. In this study, the pelvic floor-oriented treatment group had an average home exercise program compliance rate above 90%. So stressing that these vitamin exercises will help maintain their intra-abdominal pressure and correct posture while establishing a connection between the improvement of their particular pelvic floor dysfunction and the frequency of their home exercise program is vital. Now, bear in mind that this is a fairly new topic of research, and there isn't enough of it to indirectly attribute the reduction of nonspecific low back pain to pelvic floor-oriented treatment. This was actually examined in a 2009 randomized controlled trial conducted by Mahensi Benpei et al. It compared the effectiveness of supplementing pelvic floor strengthening exercises to standard treatment for low back pain. And it concluded that although pelvic floor musculature strength and endurance significantly improved in the supplemented treatment group, there was no significant difference in the visual analog pain scale or the ODI outcome measures post-treatment when comparing the supplemented treatment group with the standard of care treatment group. So basically, your patient's back pain will improve regardless of the inclusion of pelvic floor oriented treatment. Nevertheless, more research is needed to either support or validate this conclusion. This concludes our presentation. Here are our references. Thank you for your time and your attention. Have a great day.